Hello, welcome to the Mental Health for All webinars brought to you by United for Global Mental Health, Lancet Psychiatry, Mental Health Innovation Network, plus MPSS Net and Global Mental Health Action Network. Special thanks to health professionals for global health for their support. The session is being recorded and will be available on the website. If you are tweeting during the next 45 minutes or so, please use hashtag MH4all when tweeting. The webinar is going to last 45 minutes and it will be available on webinars at unitedgmh.org afterwards if you miss or if you haven't been able to join. It's my great pleasure to be chairing the webinar today. I'm Dinesh Bugra, I'm Professor Emeritus at Mental Health and Cultural Diversity at King's College London. I'm particularly delighted to welcome you to the session on migration and mental health. I think there are several challenges that we need to bear in mind. First and foremost, there are about 281 international migrants around the world who are not living in the country of their birth. But to complicate matters further, there's a lot of internal migration within the country from rural areas to urban areas for a number of reasons. And we're not going to go through the challenges in the sense of what causes people to migrate. People migrate for economic, political, educational, and lots of other reasons. But each group brings with it a different sets of problems and challenges, both for the new country and also the country they leave behind. And I just wanted to plug this textbook. We've just produced Oxford Textbook of Migrant Psychiatry, which has been very kindly supported by the Institute of Migration. So without further ado, let me introduce the panelists today, and each panelist, when it's their turn, will say something about themselves. And then there's plenty of time for the audience to ask questions. Use chat function or emails, and if we can't answer them now, we'll be able to answer them later on. So it's a great pleasure to welcome the panel today. First and foremost, from Institute of Migration, Gulli Schinina, who's been a great source of support and help to me personally, but also as a psychologist, has worked tirelessly both in Geneva, around the world, and now in Brussels. So he'll be able to say a bit more. Monica Blotevogel is from Hamburg. She is going to be talking about her own experiences in working with refugees and migrants in Germany, and I'm really looking forward to hearing her experiences. And it's a pleasure to introduce David Karorero, who's originally from Burundi, but now settled in Denmark. And it's going to be talking about his own experiences, but also what are the challenges for particular populations. And last, but certainly not the least, it's a great delight and pleasure to welcome Juliet Cohen, who works as a psychologist and a therapist, works for charity Freedom from Torture. And we have worked together on several issues. So without further ado, let's sort of go in. And Gulli, the question that I have for you is, how do you see the challenges of migration? And again, bearing in mind that there's a kind of heterogeneity in groups and reasons and so on and so forth. So we'll start with Gulli, then Monica, then David, and then Juliet. Gulli.
Thank you very much, Dinesh. So I follow your instructions. So I introduce myself briefly. I'm Guglielmo Schinina. Everyone calls me Gulli. as Dinesh said, and I'm the head of mental health, psychosocial response and intercultural communication for the International Organization for Migration, which is the United Nations Migration Agency. I am as a footprint of activities, in the psychosocial support domain in more than 80 countries worldwide so far, and has served in the last 2 years 700,000 migrant displaced population, displaced individuals and conflict-affected individuals around the world. So to respond to your question, Dinesh, I think 2021 is a year in which mental health is and will be everyone's concern, and mental health care should leave no one behind. It was never so true as in this period, and these no one behind include the diverse migrant populations, and everyone concerned include also the concern of diverse migrant population. For mental health care, yeah, I don't mean clinical support, but really a multi-tiered, all of the system effort towards social justice, mutual care, and social support. The last year and a half have been psychologically difficult for most of us, name it: isolation, having to manage your relationship remotely, uncertainty about job and livelihood, unclarity about support and social security that is available, adaptation to a new way of life in a rapid fashion, inability to understand which information is reliable or not, starting to feel that people around you perceive your physical proximity, the fact that you are close to them, as a threat rather than an advantage. And starting in 2021, also the realization that an hardship that you perceived as short-term is in fact protracting and becoming a new state of being. That you were asked to wait for a new status to come, but in fact the waiting becomes more or less the norm. I'm not picking these elements casually, but because these experiences are common to many migrants worldwide in their everyday life. They were so before the pandemic and probably will be so after the pandemic. Now they are everyone's experience. In a way, the pandemic should have made, in this sense, the psychological experiences of migrants more relatable to all of us. But this doesn't mean to any extent that the psychological experience of COVID-19 is made by this prior experience any easier for migrants. In fact, some migrants are more likely to live in precarious housing or working conditions than other populations. They have bleaker economic prospects. With the closure of borders, it has become more difficult for them to go back home if they wish to do so, but also to proceed with their travel if they are in transit situation. At the other extreme, in some situations, they are forcibly and abruptly repatriated because the hosting country doesn't want them anymore. They are even more distant from loved ones and more exposed to media disinformation because of language and cultural differences. They know the fact that this information is given in languages they might not fully master. I'm saying some migrants because, as you properly said, migrant is an umbrella term that encompasses a multitude of groups and population. For some of them, the pandemic has been particularly tough. Think about people in camps, the ones in detention or detention-like situations, the one in the pipeline for resettlement or return that have been stopped, the ones stuck in transit, the ones who had a migratory plan that is now put on hold, or the ones who just arrived at destination when all this happened, which hampered their integration to a big extent. Think about women and men who are forced, who are trafficked into dangerous working conditions or even sex work. This said, I think we should not follow in the trap that wants all migrants more vulnerable to mental health problems, because this is a narrative that feeds discrimination, objectification, and objectification of migrants. But we cannot stress enough that even today, even in the most developed countries, migrants do not enjoy equal access to mental health care, or have an access that is highly dependent on their legal status. And even those who have the right encounter a lot of practical barriers that have to do with language, cultural unawareness, of the services that are provided, lack of information, lack of outreach. To wrap up, we all need more attention to mental health in 2021. And migrants are not different from all the others. They should not be left behind in these efforts. But they should not be further stigmatized or considered more at risk by default. The response, even though some population do, obviously, but because of their circumstances. The response needs to be multifaceted and has to do with looking at structural and systemic injustice and discrimination that compound much of the additional distress migrants are facing also in these situations.
Yeah, we'll come back to that, because that sort of takes us very neatly into, the question that I had for Monica, which is about, how do you deal with migrants and refugee issues in Hamburg, and particularly in terms of barriers to mental health care. Monica?
Thanks. Yeah, I think, Gulli, you already named quite a few really relevant points in terms of access barriers, cultural understanding of how the European mental health care system works, cultural sensitivity among professionals, both in the realm of social work and in healthcare. I'd like to speak a bit about mental health care at the community level, because that's where our work is more focused, also in order not to repeat the great overview that you already gave us. So I think that some of the barriers at a cultural level, and I mean both the German culture and the culture that we as migrants bring in, one major point is difference in values. So for many of us who come from more collectivistic societies, the mental health care system in Europe, at least, is very targeted at a more individualistic understanding of mental well-being. And I think that's one area that does create more, at a communication level, barriers to accessing care or having the necessary trust that we need in order to open up about our well-being to strangers. Another point is, in terms of trust, also proximity. So just to say a couple brief words about our organization, we train peer-to-peer trainers who deliver a very basic mental health intervention and enable people to share it with their community. And what we've come to realize is that the more we're able to spread knowledge and an understanding of how to access mental health care, but also to care for each other based on the kind of scientific framework behind it, but really based on the health promoting potential of human relationships, the easier it is for people to then access care when they need it. And so I think it's really a lot about these small moments of relationships that can lower the many barriers to access that we're all quite familiar with, because most of our team have a history of migration or arriving in Germany as refugees.
That's really helpful, because I think one of the challenges that we'll come back to both David and Juliet is the challenge about how people perceive mental health, because in many cultures and in many societies, it's kind of mind and body work together, not in a kind of separate way. So the presentation can be physical of, even when they're feeling depressed or stressed, and perhaps pick up on that a bit later on. David, I mean, you've been working in Denmark with Burundian, you're doing a youth project there. Can you sort of say a bit more, and how does that sort of fit in with what Gulli and Monica were saying?
Yes. First of all, migrants arrive in host countries already for some suffering from a mental health condition before the emergency outbreak, or as suffering from PTSD, a traumatized experience they experience in the war zone or during the journey, because some of them has been tortured, others has been raped. But also those who didn't get this experience prone to develop a mental health condition due to lack of perspective or how they are treated in the host countries. So my project, Burundian Youth for a Brighter Future, supports migrants communities to rebuild their life, to give them to the hope they deserve, also to prepare them for a brighter future, because it's something important for the country, the host community, also from the country they are coming from. We do that in order to help them to to believe again in themselves, as we have a lot of broken dreams in these communities. And in our project, all is done through a preventive and immediate care. In the preventive care, we try to make some entertainment, also to help them with a specialized education support program, sport activities, extracurricular activities, in order to keep them out of the harmful use of alcohol or drugs, for example, that may lead them to NCDs, including mental health issues. For the immediate care, for those who are already affected, we connect them to professionals for a special attention and a good care. Thank you.
Thanks very much, David. But I mean, I think in a way, what you're describing is once people have reached a safe space, that, you know, what do they do? Juliet, I mean, you've been working with refugees and asylum seekers who've been through some really horrendous experiences. What's your sort of overview, and can you say a bit more about yourself as well, please?
Yes, thank you, Dinesh. So my background is actually, originally I was a GP, a family doctor, and then I've worked more and more in really what's called in the UK forensic medicine, so documenting evidence of torture. And as an individual, I can see a broader group of people who've suffered other forms of serious harm. So I examine trafficking victims, modern slavery cases, and so forth. And at Freedom from Torture, I train a team of doctors in the examination and documentation of torture using the Istanbul Protocol. And most of these cases are to provide evidence of what people have suffered for their asylum application. So what have I learned? I think it's really interesting to hear all these different perspectives. And I suppose one of the things that I've learned over time, and in particular with this sort of, sometimes it feels like a conflict, the pressure of trying to get evidence for an asylum applicant who urgently needs that report to go to court with, and yet I'm pushing them to disclose very, very distressing and difficult experiences that I know will be good material in their report, will be really helpful evidence for their case. But maybe this is not the time that they would choose to talk about those experiences. I think that for many people, silence often for a long time feels easier than disclosure. We know that much of torture involves an element of sexual assault, and this is the hardest thing to talk about. We know that most victims of serious sexual assault don't report that to the police. And in the UK, around 40% of sexual assault victims tell no one at the time of that assault. We know that survivors of child sexual assault may take many years or never disclose what happened to them, and yet it may be deeply affecting their quality of life in all that time. So I would hope that for many people that I have helped to tell about their experiences, that has in some way been helpful to them, not just for the evidence that I can then provide for them in the medical report, but also because it may help them access the treatment that they need, whether that is the specific specialized psychological therapies, or they need a sexual health clinic to advise about infections. They may need some very physical treatment for injuries that they've suffered. They may just need to know how to share what happened to them with their partner and how it's affecting their life. So I think I've really learned that it's so important for people to be able to disclose these things, and yet it's so difficult. And the tension of how to progress that in the assessment, to explain the purpose of questions, to be a good listener, to try to pick up on cues and clues that maybe there is something there that perhaps they are ready to talk about now, and how to sensitively listen and be their witness to what they've experienced. I think for me, those are a constant source of new learning and new experiences.
Yeah, I mean, I think there are challenges in terms of, when you're arriving in a new country, how much of your history do you disclose? Because there's always a worry that you'll be stigmatized, A, for being refugee, B, if you have a mental health problem, C, if you've been sexually abused. And particularly, I mean, do you see, Juliet, in your work, differences between men and women? And, do they respond in different ways? Men who've been sexually assaulted and women who've been sexually assaulted and abused? Are there kind of the gender differences? And what should we be doing as clinicians to try and overcome that?
So actually, I find now the gender differences are less than they used to be. I've been doing this work for a little over 20 years. And I think when I started, it was not that common to have women disclose sexual violence. It was rare for men to be able to talk about it. But the more it's become a general topic in our society, and people have become more and more open about it in all sorts of different media, I think it does help people to speak about these things. They feel it's less stigmatizing, particularly when they're talking to a healthcare professional, and that they won't be rejected for telling that, and also a better understanding of how we can keep disclosures confidential, which is really important still for many people. So yeah, I do find that more and more men are able to disclose, and that perhaps upturns our understanding of the prevalence of these experiences for people, where we used to think that, oh, it's something that happens to women and men are somehow able to resist. But actually, particularly in the context of torture and detention, then, people are not able to resist, and it's happening to people of different gender identities, different sexual orientations. Many people are vulnerable, and more people are able to speak about it. So it's really important for everyone to be open to the clues for disclosure when people are ready. And I think particularly also to offer a gender choice where possible, in the therapist, in the interpreter, in other clinical professionals who may be involved, because not everybody wants to speak to the same gender as themselves. They may want to speak to a different gender alignment, and we have to be open to asking that.
Thanks. Gulli, I mean, you kind of, been around the world, looking at different settings and different sets of problems. I mean, do you find that gender difference plays a role, that men and women tend to respond differently, both to the approaches in terms of migration and help seeking as far as their mental health is concerned?
Yes, absolutely. Yes, as I said, also this paradigm is shifting, so we cannot really have, it's not like a monolith, and we perceive it as such. But in fact, there are differences. And I would say that mental health for men, especially in our field, is the so-called elephant in the room. It is an obvious need, and yet no one, or very few people, really want to deal with it because of several reasons. The first is the categorization and prioritization of vulnerabilities that is inherent to humanitarian and emergency responses, and at times jeopardize complexity and individual needs. According to this categorization, in all our protocols, women and children are vulnerable. Men are not as much, regardless of their individual circumstances.
Right.
The second is that in an environment where care is much more and more legalized, and somehow attributing blame is part of recognizing victims, as the former speaker was saying. And being a victim is often the easiest pathway to receive care or even citizenship. No matter who the victim is, a man is most likely the perpetrator. This is true in sexual violence, but also in many other forms of violence. And this is true, and it is also true that toxic concepts of masculinity persist everywhere in the world. And yet, not all perpetrators are male, and even more so, not all males are perpetrators. And paradigms of masculinity, as I say, are shifting to a big extent. Lastly, men usually do not cry. Have been usually taught not to. and are not as easily attracted to mental health services that are not very creatively often centered on talking to someone else to vent feelings, something that is unacceptable for many cultures, as we all know. This doesn't mean that men do not suffer, since they are often exposed to violence and abuse in the migration process. They lose their traditional roles. They are subject of objectification, of discrimination. They very often lose their sense of self-worth. There is a lot of frustration of their expectation, as David was saying, and many others. And when they suffer, the needs are not met, then their own families, their larger social structures, including the system in the destination countries, are unlikely to be well. So that's an issue. But these are not philosophical arguments, because they bring to a situation which for me is very worrying, in which men are usually underrepresented in all our programs of psychosocial support. The activities that David was mentioning, support groups, creative activities, recreational activities, they are much less than they should be in these activities, but then they are overrepresented among those who seek psychiatric care. So there they are overwhelmingly male who seek psychiatric care in our programs. This is a worrisome proportion that tell us that needs are there, but they are disregarded till they become pathological. So that's the only time when then, men seek for help, and often, then become a clinical care, which is in reverse stigmatizing access to mental health care even more. So I think, that we should do more in this field. As this psychosocial professional myself, I faced this problem in the last 20 years. Whenever I was working with male victims of human trafficking for sexual exploitation, with victims of rape, with adolescents traveling unaccompanied, migrants stranded in detention in an identification center, who are for the overwhelming majority males, like in Libya, but also in Europe, and there is very little, I could refer to. And there is also, I have to say, a bit of an attitude of the system to perceive men as non-vulnerable. So it's more difficult for them to access services, even if they wanted. And also there is an issue of the genderization of the profession. More and more, the youngest generation of psychologists, and counselors are overwhelmingly females, which obviously bring also to, by default, and almost naturally, to a different approach to whom to prioritize, but also to the kind of care that is offered.
Thanks very much, Gulli. I mean, that kind of takes us very neatly into the work, Monica, you've been and your organization have been doing in Hamburg, working with younger people and younger families. I mean, I think that there are sort of two issues as I see them. One is at a sort of real practical level, how do we help young families, children, and, in adjustment? But the second and much bigger issue is that of policy level. So how do you think we can sort of develop on both of those?
Yeah, I think there's two different directions that would really help at policy level. One would be really speeding up the asylum process and enabling families to access employment as fast as possible, because mental health is a social question, and having your basic needs covered and resecuring the status that you might have given up before migrating to a new country, that could play a huge role in preventing mental problems in the long term. So I think that's one major policy around migration and asylum laws that could really use more improvement. It has seen a lot of improvement in the past 5 years, but there's still a way to go. The other point, coming from the other direction, I think, is also at community social work level. I would say more diversity among professionals. I don't know how we can change this, but I absolutely agree with you, Gulli, that in mental health professionals, it is a predominantly female profession. We'd all like to see that change, but what I would also like to see is more diversity among the people who are caring for underserved and marginalized populations, cultural diversity. I think that's another thing that we could actually target more specifically at policy level, rather than just saying it would be a good idea. And then also training among professionals, among family doctors, social workers, etc., just to sensitize people for possible barriers and how to address those couple issues that I mentioned before. And then at there's one more point that is really, I'm very biased about, but I think that also the German insurance law needs to change to support peer-to-peer approaches more than it does. Because in Germany, if you're providing a community-based intervention, it will only be funded through the insurance companies if you are qualified in psychology, social work, or medicine. And I think everybody is crying out for more peer-to-peer community-based approaches, but it's not yet anchored in policy. So that's another development that I would really like to see happen.
David, I mean, as somebody who's been through the process, and you said in your introduction that you've been training peer-to-peer support. What would your advice be to policymakers and clinicians alike as to what is it that we ought to be doing, which we haven't been doing, or it's also about the sort of how do we make sure that populations who migrate stay mentally healthy?
Yeah.
I think we are made victims by policies and not given the chance and equal treatment. First of all, we are labeled as a migrant before being labeled as human being. So we need the international solidarity on this issue to equally share the responsibility so that our rights are observed. For example, have the right to health equity, the right to have mental health psychosocial support, especially for those who has been in those experience in a war zone. Also, the right to education. For example, education can keep out those young people, keep them out of the use of alcohol, drugs that can lead them to mental health issues. Also, we need that policymakers give us the opportunity of being part of a solution from designing, implementation, and evaluation, because we are just called as an afterthought. And it's really important for them to know that there is nothing for us without us, and know that we are the solution, not the problem. So we need to sit on the same table and fix the issues together with policymakers, because we are in this together. No one is safe until we are all safe. Thank you.
Thanks very much. I mean, Juliet, the questions are beginning to come in. I mean, one of the questions which has been raised is that particularly now, and again, Gulli may be able to add that with, lot of clinical consultations are being done on Zoom rather than face-to-face. So lots of sort of migrants and refugees and asylum seekers might be contacting people back home to get their input into their stress and distress. And so what are the kind of lessons that we need to be, as clinicians, we need to be aware of? The kind of, I mean, one thing that sort of strikes me are the mixed messages, and particularly, as I said earlier, that quite often the link between mental health and physical health is very different across different cultures. So that may create some tensions with the Western system. But I mean, do you have any advice as to what the clinicians ought to be doing under those circumstances?
Yeah, it is a really interesting challenge, and I think we have learned a huge amount in the last year. At Freedom from Torture, we had to switch from doing in-person assessments to doing a psychological remote assessment and pausing the physical assessment for scars until we could see people face to face again. And we decided that because this was such a big change in practice, we should audit it very carefully to see if it was affecting the quality of the medical report that was produced, and also to see how our processes were working for risk assessment, because it feels very different to speak to someone remotely. Most of our asylum seekers in the UK would be living in a room alone, a small room. Some were in shared rooms, in crowded accommodation. perhaps without any of their normal supports around them, so that if they felt distressed during the assessment or after the assessment with all the triggering and memories coming back to them, who would they go and talk to? They weren't allowed to leave. Could they go? They couldn't see their therapist. They couldn't see their GP. They had no support group, no community groups available to them. So we were really careful to try to risk assess every referral and consider whether it was appropriate to see that person in the remote context, or actually it might be better for them to wait until we could see them face to face. Because when we're face to face, we are so much better at picking up the clues. We can see body language. We can have kind of the fluency of communication that you don't always get remotely, particularly if somebody's just using a phone or if the connectivity isn't very good. So I felt very concerned about that and about people's ability to really articulate clearly and communicate what they wanted to say in the remote setting, where it just feels harder to establish a rapport and a feeling of trust. But against all that, we have to set the stress of delay. And can people wait? What does that do to them? So we've had to juggle that, and it's been an ongoing question for us.
Because I mean, I think one of the big challenges quite often, I mean, you know, particularly when you've been through a very traumatic experience, and if you're a refugee or an asylum seeker rather than an economic, I mean, I always use the example that, you know, pop stars may have a house in Malibu Beach and a house in London and a chateau in Switzerland. Their migratory experiences are going to be very, very different. So we can't sort of just use that. But one of the things that sort of interests me, and the point that both Monica and Gulli made earlier about the sort of matching of the therapist with the migrant, and you know, but do you feel that there is also a danger that we might end up medicalizing normal human responses of anxiety and depression and stress if you lost everything, you know, lost your family, you may have lost your belongings, you know, you're just there by yourself. So how do we, I mean, what are the lessons for clinicians that how do we stop that and make sure that we're not sort of pathologizing normal responses? Monica, may I come to you first?
Yeah, that's so that's pretty much at the core of what we're trying to do with our project, is to really spread more awareness for the mind connection and how a lot of the stress symptoms that we show are a totally normal, adequate response to the experience that people have been through. And we try to focus on how we cope with situations like that and give people tools so they can share with each other in order to try to normalize rather than pathologize, and also shift the perspective to strengths that help people arrive at a place of safety where these kind of reactions, these responses maybe become less necessary.
Yeah. Gulli?
No, I totally agree. And well, we know each other, so you know that our work is very much focused on that, you know. The fact that, you know, pathologizing migrants is not serving migrants, you know, because it built into the discrimination, the objectification, but also the system requires us to do so, because suffering and psychological suffering is somehow an entry door to integration, not to integration, because then, you know, it compounded, but it has entry door to the certification of your vulnerability, and therefore to citizenship, you know, or permit of stay, or, you know, easier asylum procedure. So that's also an issue that we provoke with the entire system that require vulnerability in order for you to be accepted, you know, paradoxically. On the other side, I wanted to make just a last remark on access again, no? Because we are talking about access, you know, counseling, whatever. However, we have to know that especially irregular migrants, because asylum seekers have, but irregular migrants, even in developed countries like in Europe, don't have access to mental health care, don't have the right still, you know, to access mental health care. And when they have, there are a lot of these require identification. So basically, you know, you have to subscribe. That means that most of them won't do it, you know, because it's dangerous for them, and they think, you know, this might jeopardize their stay in the country. And also, so basically, we really need to mainstream more mental health at the primary health care level, because that's the way in which we can solve the problems of those, the minority who has actual severe mental disorders and need care.
Thank you very much. I think we've got 5 minutes left. So a minute to each of you for your concluding remarks. And I'm going to start with Monica.
Oh, okay. Yeah, I just wanted to get to what Gulli said at the beginning, is that the experience that we're all going through right now, uncertainty, not knowing what's coming next, waiting with an uncertainty as to whether is this waiting or is this normal. I really liked how you put that is basically the experience that we go through as migrants when we are marginalized, obviously, not if we can just move to our chateau. Yeah, so I just wanted to pick that up again at the end. And my hope is that it will help us all relate better to that experience of dealing with uncertainty, and maybe also to appreciate more the resilience, or what we can learn about resilience from people who have gone through that experience. Yeah,
that is a very good point. Thank you. David.
Yes, I think there is an urgent need of the integration of mental health psychosocial support into the existing service provision in the routine of every refugee and IDP camp. Mental health support is highly under-recognized in the emergency setting. However, the financial and societal implication in regards to their chronic costs are very huge. Without that support, migrants prone to develop mental health condition due to the lack of perspective, as I said before, but also there is a deterioration of mental health condition from those who has been through a lot, who has been raped or tortured. Thank you.
Thank you. Juliet.
Yeah, I just wanted to turn to what we don't know what we don't know. We do know that migrants and people of different ethnicities have different access to and experiences of mental health care. But suicide is a tragedy that we know too little about, and we don't really know how effective suicide prevention programs are. How do we know if they're reaching everyone that we want them to reach? In the UK, what is missing is any collection of national data on the ethnicity and migration status of suicides. Coroners who report on suicide deaths to the Office for National Statistics, they're the people and the organizations who are placed to gather this information. And Dinesh and I have been asking them to do this, but they continue to dodge this issue. So if all lives matter, why aren't we looking at this? Why don't we know the ethnicity and migration status of suicides?
Thank you. Gulli.
Well, for me, I want to conclude with 4 probably recommendations. It's working more with the community. I think that's extremely important. And starting with the needs of the community. Do not pathologize the normal reactions to the abnormality of situations. However, take care of the ones with severe mental disorder and moderate mental disorders. And this can be done with more mental health at the primary health care level, with more legislation that allow access to all migrants to all levels of care, and also with cultural awareness from the service provider. I think migration is now a new item of today's anthropology. Psychiatrists, doctors, educators, and social workers need to relate with cultural diversity. So this has to be part of their formal curriculum, and accreditation processes. They don't have to know any culture, but what is cultural diversity and how to approach it, in a relation.
Yeah. Thanks very much. Thank you all very much. I mean, it's really been thought-provoking, and I hope we can come back to, because there are lots of issues that we still need to discuss. I mean, the whole idea of geopsychiatry and what's going on globally and what that means, creating migrants, and what the policy implications should be. And it's really both at a personal level and at a sort of policy level, we need to sort of tackle those things in a very sensitive way. And the idea of cultural competence training is an incredibly important one for all clinicians. In summary, that is good clinical practice. So you have to sort of look after the patient sitting in front of you, his or her circumstances and their kind of cultural values and their narratives to make sense of what they've been through. So I think we've just reached the end of our session. Thank you all very much for joining. Thanks to the panel. The next webinar is going to be on 6th of April on child psychiatry. And hopefully we will come back to the question of migration and at another point, and hopefully you'll be able to join us. And once again, thank you all very much for joining, and thanks very much to the panel. Thank you.
Thank you. Bye-bye.
Bye.
Thank you, Dinesh, for leading the conversation.